Under the following headings: Introduction, Epidemiology, Etiology, Pathogenesis, and Natural History. Then we'll go into its classifications, then what we investigate, the management, and the sequelae of Perthes disease. Basically,
Can
Perthes
you go
disease is
full
defined.
screen?
I am on full screen on this.
No, you're not. Double click that full screen mode at the bottom.
Is it full screen now?
Yeah, but the slides are not advancing. It's not full screen to us.
Disease under the following headings:
Mhm.
uh, Introduction, Epidemiology, Etiology, Pathogenesis, Natural History, Classification, Investigations, Management, and Sequelae. Perthes disease is it is defined as the proximal epiphysis avascular necrosis, osteonecrosis, and chondronecrosis of the proximal femoral epiphysis. It occurs due to the disruption of the blood supply of the capital femoral epiphysis to a variable extent. It is usually a self-limiting disease which commonly occurs between 4 to 8 years of age. It is more common in males, the ratio being 5:1. Then we'll talk a little bit about its history. It's called leg calf Perthes disease because it was in 1910 described by Arthur Legg. He suggested its association with a trauma with painless limb. And Calf, who also described about the minimal atrophy of the leg with no hip swelling. Mainly Perthes, he described it as a self-limiting, non-inflammatory condition affecting the femoral epiphysis with stages of degeneration and regeneration, which leads to restoration of the bone nucleus. And another major contributor was Waldenstrom. He tried to associate it with tuberculosis, uh, and he also had major contribution in staging the disease, the clinical progression. And talking about epidemiology, it can affect children under the 15 years of age, but most commonly occurs between the 4 to 8 years of age. And as I said earlier, male is to female ratio is 5:1. And in 10 to 15% of cases, there is seen to be a bilateral involvement. The incidence of this disease varies from one region to another. It varies from zero point 0.2 to 19.1 per 100,000 uh, people, children, and but it is highest in the northern European region. In India, the incidence also varies as it is more common in the southwest region. It is almost 10 times more common in the southwest region as compared to the southeastern region. In talking about races, it is more commonly seen in Caucasians rather than African or Asian population. Now, risk factors. A predisposing child is with a systemic abnormalities of growth and development, and in those, it is seen that it has an alteration in the IGF-1 pathway, and also it was noted that in it is 4 times more common in the socioeconomically deprived households. In the UK, the incidence of the disease has halved from 1976 uh, till 2009, and that is associated with improved standard of living amongst the population. Also, association have been established between smoking, the parental smoking or passive smoking, which causes fibrinolysis, which causes venous occlusion and leading to epiphyseal disruption. A strong association has been suggested with ADHD or hyperactivity, and uh, also some hemoglobinopathies and type 2 collagen mutations, protein C and protein S deficiency coagulopathies are also associated with causing vascular occlusion, causing leading to Perthes disease. It has been suggested it could be a result of a mechanical stress or trauma, which also associates with the hyperactivity uh, hypothesis. Now, the hereditary influence uh, is not established much. Any familial aggregation is usually attributed to uh, environmental occurrences and not due to genetic susceptibility. It has 0.5 to 0.8% among the parents of affected children and 2 to 4% among the siblings of the affected children. Talking about the disruption of arterial flow, Perthes disease, the blood supply of the lateral epiphyseal arteries is impaired at their origin. The revascularization occurs from this site by ingrowth of small vessels into the femoral epiphysis. It can be so that there are recurrent ischemic episodes. These conclusions were drawn by doing angiographic studies by Takashi Atsuno. Uh, Talking about its pathogenesis, there is disruption of blood supply to the femoral head, which leads to an ischemic necrosis or osteonecrosis and chondronecrosis over the femoral head, and thus leading to structural changes of the femoral head. Diagrammatic representation of how lateral epiphyseal arteries function. It's a branch of a medial circumflex arteries, and at the age of 4 to 8 years old, lateral epiphyseal arteries are the major contributor to the blood supply of the epiphysis, femoral head epiphysis. And it depends on the level of occlusion, uh, and that will define the extent of involvement of the femoral head. It was also noted that there was, after the incidence of vascular insult, there was a rapid recanalization as well. But due to epiphyseal collapse or that recanalized vessels can also get obliterated. Now, there was a discussion in the pathogenesis of Perthes disease that whether it's attributing to trauma, whether it's a single episode trauma or whether it's a single episode ischemic uh, infarction or versus multiple episodes. So femoral biopsies were conducted, and out of the specimens, 51% of them found to be displaying changes similar to those seen with double infarction, in which that laminar bone were surrounded with a thick surface of layer of dead woman bone. Now talking about the stages of clinical presentation, the stages of the disease in the pathogenesis. In early stages, there is synovitis, and that trabecular bone and marrow necrosis occurs, and that leads to a necrosis of deep layer of epiphyseal cartilage, and articular cartilage gets thickened, thus leading to subchondral fractures or separation of cartilage and bones. Then trabecular bone fragmentation can also be seen, uh, and physeal disruption is also seen. Cartilage extended from physis into the metaphysis. The next stage is of the stage of fragmentation, in which there is the invasion of vascular granulation tissue in the marrow space, and increased vessels in the cartilage are seen, and increase of osteoclast and bone resorption in the bony epiphysis, restoration of endochondral ossification in the periphery of the epiphysis. This is basically the revascularization stage. Then reossification stage, in which there is no new bone forming on the old trabeculum and woven new bone formation takes place. In healing stage, new bone, woven, and lamellar bone all are seen, and gradually the femoral head returns to normal architecture. This is the natural evolution of the femoral head as described by the study by Benjamin Joseph. And in the stage 1A, there is no loss of height of the epiphysis. In stage 1B, the epiphysis is sclerotic, but there is a loss of epiphyseal height and no evidence of fragmentation of the epiphysis. In stage 2A, uh, the epiphysis is sclerotic and just began to fragment. And 2B is advanced fragmentation in which no new bone is visible, but multiple advanced fragmentation is visible. Stage 3A is where the newborn formation starts appearing, early newborn formation, and it covers less than the third of the width of the epiphysis. And in stage 3B is the stage of advanced newborn formation in which the newborn covers more than one third of the epiphysis of the width of the epiphysis. Uh, these are Waldenstrom stages, in which basically initial stage is characterized by the sclerosis and which suggests the avascular necrosis. And then second stage is fragmentation. Third stage is reossification. And fourth stage is heel stage, which reflects the final shape of the femoral head. Waldenstrom stages were further modified into stage 1, 2, and 3 were differentiated into 1A, 2A. 1A, 1B, 2A, 2B, and 3A, 3B. In 1A, there is just sclerosis visible. And in 1B, there is, apart from sclerosis, some loss of height and subchondral fractures are visible. In 2A is early fragmentation stage in which few fragmentation and even metaphyseal cysts can be seen. In stage 2B, multiple advanced fragmentation is visible. In stage 3A, it's initiation of reossification. So basically, less than one third of the femoral epiphysis starts ossifying. 3B, in which more than one third of epiphysis is ossifying. And stage 4 is completely healed femoral head. Now, deformation phase is the phase in which the maximum risk of femoral head deformation, and it occurs during the fragmentation stage. And in this stage is where loss of lateral peroneal height occurs, and that is a key predictor of poor outcome. Extrusion of femoral head, it leads to the acetabular mismatch and further deformation. And mechanical containment during this phase is important to prevent further collapse. Coming to clinical features of the disease, patients present with limping. Most commonly, they present with hip, or even very commonly, we can see there is knee and thigh pain associated. This pain is insidious in the onset and it aggravates with activity. There can be a possible history of trauma associated with it. In signs, there is going to be a limp, and the gait type is going to be a Trendelenburg or associated with an antalgic gait. Uh, Range of motion is restricted, as the first thing that gets restricted is internal rotation usually, and abduction also gets restricted in advanced stages. Uh, Clinically, there is an obligatory external rotation. Basically, when patient is asked to actively flex the hip, it goes into external rotation. In cases of collapse with femoral collapse of the femoral head, there can be a shortening also noticeable. And Trendelenburg test is positive. That is a significant uh, indicator of abductor insufficiency. Investigations where we most commonly rely on X-rays. MRI are mainly of MRIs, and arthrogram can also be done. In X-rays, there is increased density in the femoral head, and there can be an apparent widening of the joint space. And such is the initial stage of Waldenstrom, in which hip synovitis also occurs, due to which the femoral head and the apparent widening of the joint space occurs. Then in further advanced stages, there are fragmentation. and there is a lateral extrusion of the lateral pillar of the epiphysis. And in lateral pillar classification system, in this X-ray, it can be seen that it is uh, as per the lateral pillar classification, it is Group B. We'll describe it in further discussion. And then stages of early reossification, there will be a increased increased uh, density of the bone in the femoral epiphysis. There, in acetabular changes, there can be a bicompartmentalization of acetabulum. And in this X-ray, we can also see the lateral pillar is also getting extruded. Then in heel stages, there is improved roundness, progressive improving of roundness, and remodeling of the femoral head occurs, and gradually the femoral head becomes better congruous. Then metaphyseal cyst is an important sign that occurs, which is basically a cystic region seen in the femoral neck metaphysis, and it can also be noted in the MRI. Sagging rope sign is a rope-like radiodense line across the intertrochanteric area, which represents the edge of the enlarged femoral head or coxa magna. Then we can also see in worst cases that trochanteric overgrowth occurs, causing short femoral neck, coxa breva, and caput valgum also occurs in such cases. Caput valgum or caput magnum uh, can also be seen. MRI has significance in early diagnosis in which only sclerosis is visible and there is no collapse. So just to predict the outcome and just to predict the involvement of the femoral head, the epiphysis of the femoral head, and also to evaluate the extent of the avascular region. Or it can be used in the heel stages in which the sequelae has to be assessed, such as FAI, femoral acetabulum impingement. If there are any cartilage and labral pathologies associated with the Perthes disease after the head is healed up, a MRI can be useful in such cases to assess. Arthrography also has its usage. We can visualize the joint space widening by doing an arthrogram, and lateral shifting of the femoral head and the lateral extrusion of the femoral head can also be visualized. The changes of the femoral head shape can also be visualized, and most importantly, it's a good tool to assess the congruity of the femoral head. Coming to classification, now classification amongst classification, category classification. It has four stages. It is based on AP and lateral X-ray, and it is usually classified at the stage of fragmentation. Group 1 is basically when only the anterior portion of the epiphysis is affected and when there is no collapse. And group 2 is when there is involvement of anterior epiphysis with the central sequestrum, and medial and lateral segments remain viable, and the epiphyseal height is also maintained. Group 1 and Group 2 are usually associated with better prognosis and better outcomes. Group 3, most of the physis is sequestered, and there can be seen a head within a head appearance, and there can also be a loss of height and broadening of the femoral neck. And in Group 4, there is total epiphyseal involvement, and mushroom appearance can also be seen. Group 3 and Group 4 are usually associated with worse outcomes or bad prognosis. Catterall also described what are known as head at risk signs, which basically included five uh, things. Basically, a gauge sign, which is a V-shaped radiolucency in the lateral portion of the epiphysis uh, or the adjacent metaphysis, and calcification of the lateral calcification visible lateral to the epiphysis. It indicates the bone forming outside the normal joint area. Metaphyseal cyst, which is a small fluid-filled lesion in the neck of the femur in the metaphyseal region. Lateral subluxation is the displacement or extrusion of the femoral head out of the socket. And horizontal proximal femoral epiphysis. Basically, the angle of the growth plate is horizontal than normal. So a change in the angle of the growth plate is associated with a worse outcome. Then Herring's lateral pillar classification, in which group A shows no apparent changes. There is no density change or no loss of height is there. In group B, there is some density change, but the height of the lateral pillar is maintained more than 50%. And there is a collapse of the central pillar. In B or C intermediate group, there is a thin lateral pillar and the height collapse is approximately 50%. And group C is where the height of uh, the collapse is more than 50% or the lateral pillar height is less than 50%. Then Salter-Thompson classification is basically a classification based on the subchondral fractures. Uh, and it can be staged only in the initial stages. And the drawback of this is that subchondral fractures are not seen in all the cases. It's only seen in 30% of the cases. So this classification cannot be extrapolated to all the cases. Uh, the classification divides in two groups, Group A, in which there is less than 50% involvement, and Group B, in which there is more than 50% involvement. And Salter and Thompson described these Group A and Group B. Group A would have better outcome, and Group B would have worse outcome. Then the most important classification that we see, that we use regularly, is the modified Elizabeth-Town classification, in which stage 1A, it has all or part of the epiphysis is sclerotic. There is no loss of height of the epiphysis in stage 1A. 1B is the sclerosis of epiphysis, and there is loss of epiphyseal height, but there is no fragmentation of the epiphysis. In stage 2A, the epiphysis has just begun to fragment. Uh, one or two vertical fissures or fragmentation are present, either in the AP view or the frog-leg lateral view. In stage 2B, fragmentation is advanced and there is no newborn lateral to the fragmented epiphysis. In stage 3A, there is early newborn formation and it is visible lateral to the fragmented epiphysis. The texture of the newborn is not normal. It is more porotic and covers less than a third of the width of the epiphysis. Newborn in stage 3B is normal texture and covers more than one third of the width of the epiphysis. In stage 4, the healing is complete and there is no radiographic evidence of avascular bone. Now, coming to the classification of end results. Basically, after the healing stage, the end results, the deformation of the head and the classification, which so Moses classification, it uses concentric circles, a template of concentric circles, and the shape of the femoral head is included in it. And if there is less than 1 mm of difference in the shape of the femoral head with the concentric circles, then it is assumed that it can be a good outcome. And if it is within 2 mm, then it's a fair outcome. And if the shape of the femoral head is more than 2 mm of the concentric circle, and then it is associated with poor outcomes. Then Stulberg classification. In Stulberg classification, group 1 is where there is femoral head appears to be normal. Group 2 is the femoral head which is round with within the 2 mm of the circle and same circle in both the views. It remains within the same circle in both the views. Group 3 is where femoral head is ovoid and acetabulum matches the head. And group 4 is flattened femoral head more than 1 centimeter on the weight bearing areas. and acetabulum is also flat. And group 5 is femoral head is collapsed completely, but acetabulum is not flat. Then we'll talk about sphericity deviation score. It was given by Dr. Hitesha and Benjamin Joseph, in which there were in the epiphyseal line, there are we draw a circle, uh, keeping those 2 points as the medial and the lateral point of the epiphysis as the reference points, and we draw a circle around it. And then we also include the extruding portions into the circle, into another circle, and uh, the roundness of these circles are the radius of these circles are calculated, and the roundness error of anteroposterior radiograph and roundness error of in the lateral radiograph is calculated. The sum of roundness error of anteroposterior radiograph, the lateral radiograph, and the epi epiphysis, it is added, and a sphericity deviation score is taken out. Sphericity deviation score of less than 10 is suggestive of good healing, or it will fall inside the Stulberg 1 type of hip, one or two type of hip, which is suggestive of a good outcome. Coming to differential diagnosis, there can be known causes of avascular necrosis, which are sickle cell, hemoglobinopathies, CML, steroid medications, sequelae of a traumatic hip dislocation, and post-treatment of DDH, and even in septic arthritis. It can also mimic skeletal dysplasias like SCD, MED, and mucopolysaccharidosis, and it can also be seen in other syndromes like osteochondromatosis and metachondromatosis, Stickler syndrome, and Schwartz-Jampel syndrome. Coming to treatment, we have primary goals of treatment. The primary goal of treatment is to maintain the containment of the femoral head within the acetabulum. Uh, then we also want to preserve the range of motion of the hip and preserve prevent the femoral head to deform. Basically, preserve the shape of the femoral head. And long-term objective is to delay or prevent osteoarthritis. So treatment options are, first one is the weight relief, in which we do activity restriction so that collapse does not occur during the stage of fragmentation. Then containment, it can be by bracing or casting after improving the range of motion to be kept in abduction and internal rotation. And there are options for surgical containment as well. And then growth modulation, or a GT apophysiodesis, or trochanteric epiphysiodesis. Talking about conservative management, in which we maintain the joint mobility and keep the mechanical stress reduced by keeping the patient non-weight bearing or minimally weight bearing. And we also advise gentle range of motion exercises of the hip along with traction application. Uh, by reducing the mechanical stress, we can also induce a natural remodeling of the femoral head. Then talking about containment. Containment basically means to position the lateral extruded portion within the acetabulum. So for that, we need to abduct and internally rotate the hip. Containment works best, optimal timing for containment, as suggested by a study by Benjamin Joseph. Uh, it, it shows best outcomes in stages 1A, 1B, and 2A. But prerequisites for containment is that we require a good range of motion, and it need to be carried out before the stage of fragmentation gets over. And there can be no hinged abduction. If hinged abduction is present, then containment would not be effective. Here are a few methods of containment apart from the regularly followed Petri casting, in which we broomstick casting or Petri casting, in which we place the hip in abduction and internal rotation and cast both the legs. There is an A-frame base and Atlanta Scottish right brace also described. Now, options for surgical containment, in which basically we are reducing the extruded femoral epiphysis inside the hip. There are multiple options for the same. Uh, a proximal femoral varus osteotomy, or innominate osteotomy, a Salter's osteotomy, triple innominate osteotomy, a shelf acetobuloplasty, or Chiari osteotomy. Now, talking about the most widely done procedure of femoral varus derotation osteotomy, it's a subtrochanteric osteotomy, uh, which in which we do the osteotomy at the subtrochanteric level, and the distal fragment is abducted, and distal fragment is adducted and externally rotated, adducted and is externally rotated, and we achieve the 20 degree of abduction in the proximal fragment at the hip. And the chances of the retaining the stiff sphericity of the femoral head were much higher in children with who had undergone the femoral osteotomy. This was suggested in a study conducted by Dr. Benjamin Joseph, in which he compared the outcomes of people who had undergone surgical containment by VDR and otherwise conservatively managed patients. And such results are most evident when the operation was performed in the either stages of avascular necrosis or in the early stages of fragmentation. This is an example of a case that we had done recently. As we can see in the first preoperative X-ray that there is a lateral extrusion of the hip, which was later on uh, a good range of motion was gradually achieved by keeping the patient non-weight bearing and on traction. And gradually, after achievement of good range of motion, femoral varus osteotomy was done. And as we can see, gradually it is progressing in the natural history of its course, natural course of the Perthes disease. Now we'll talk about pelvic osteotomies. Salter's osteotomy is basically a transaction which we do above the AIIS to the greater sciatic notch, and then we can direct the entire entire pelvis, uh, the superior portion of the acetabulum. It can be redirected anterolaterally, and thus improving the coverage of the hip. Then coming to the triple pelvic osteotomy, it is usually done when there is reduced elasticity of the pelvis. Three osteotomies are done. One is Salter's, one superior pubic ramus, and one at the ischium. And anterolateral redirection is done and fixed, again achieving the coverage that we require. Then shelf acetobuloplasty. Uh, it is basically an extended lateral shelf to cover the enlarged femoral head to maintain under the acetabulum to contain the subluxated hip, and it is this study done by Mandar sir, Sandeep sir, and Patwardhan sir suggests that the self-acetobuloplasty also restores hip range of motion in advanced stages of the disease. Then periacetabular osteotomy or Bernese periacetabular osteotomy, in which we do an incomplete osteotomy of the ischium, a complete osteotomy of the pubis, and supraacetabular and infraacetabular osteotomies are also done. And the entire acetabulum is then redirected or rotated, thus achieving the coverage. This procedure is usually done after the closure of the triradiate cartilage, is only preferred after the closure of the triradiate cartilage. Then talking about the complications and sequelae of the Perthes disease, hinged abduction is the most commonly seen. The lateral pillar, in cases where lateral pillar is widely affected, uh, the epiphysis cannot enter the acetabulum. It causes medial pooling and displacement, and in during abduction, the head gets levered out by the superolateral part of the femoral head, hitting the acetabular ring. So, in cases in which it is irreducible, we can perform a femoral valgus extension osteotomy, thus keeping the lateral pillar uh, away from the away from hitting the abutting the acetabular ring. Or it can be covered by a shelf acetabuloplasty procedure, thus increasing the coverage and containment of the lateral pillar, and thereby increasing the range of motion as well. Coxa vara and high riding trochanter is also seen in poor prognostic patients. Uh, in that, there is a painful restriction of the range of motion of the hip. For these patients, trochanteric epiphysiodesis is also suggested, is also described. Uh, and along with that, a Marshall's femoral neck lengthening osteotomy is also described. Now, talking about hip preservation, in which surgical dislocation is also it allows a comprehensive access to the femoral head. Uh, by doing the surgical dislocation, we can do osteochondroplasty or preserve the native hip function. And femoral head reduction osteotomy is a described procedure in which aspherical femoral heads are reshaped and the femoral head congruency is improved. And but it has severe complications. So it is a potential complication of permanent AVN or destruction of the head, as it is not very commonly performed. And it is done for the cases of coxa magna or aspherical femoral. Thank you.
Sandeep, you first. एंड तो कर प्रॉपरली स्लाइड शो. So very sketchy, Karthik. But do you really think about your slides when you're making it and speaking it? See, Walden-Storm modification you showed and Elizabethtown. It's actually Elizabethtown only. Walden-Storm is just the stages. Hello?